Just we will revise the diets. So, who is sleeping? ఎవరికి నిద్ర వస్తుంది? ప్రశాంత్. రాత్రి చాలా కేసెస్ వచ్చింది. ఓకే. Anyhow, it's coming. It is big thing. So these were the things which we have discussed last time. Okay. So regarding this, the basically we are doing the EP study for 2-3 things. So pre-evaluation means when the patient is having bradycardia or syncope or giddiness, these three complaints, and we are getting a normal ECG or ECG with the pauses. So in this situation, we have to go for the Brady protocol. There is a Tachy protocol and second called Brady protocol. In Tachy, we are going to induce the tachycardia, which is not been coming in the normal ECG, and we are suspecting. So in Brady, first, when we have to suspect. So some patient will be having a Holter study, and Holter study, we are getting some whatever finding in favor of that. If it establishes the diagnosis, means we are getting a pause, big pause of more than 3.5 seconds, or patient is having tachybrady, or patient is having bradycardia, which is coming around 2.5 second. So these are 2.5 second with syncope, all those things. So it is not that difficult to pinpoint the diagnosis because it is already established on the ECG. But sometimes the sinus ECG, or you can say baseline ECG, is not abnormal. Only some findings we are getting that one or two ectopics are coming. Sometimes pauses are coming, but they are not significant. They are coming around 2.2, 2.5, 2.7. So 3.5 in a sinus and more than 5 seconds in atrial fibrillation, the pauses are considered as significant. 3.5 in the sinus and more than 5 seconds in the atrial fibrillation. If you're getting a pause, that is called significant pause. There is no need of doing the EP study. You can directly give the choice for putting a pacemaker in that patient. So what we are looking for. So sinus nodal disease is one of the diseases in which the sinus is not functioning properly. And what other things can happen? Patient may be having atrial fibrillation. Patient may be having sinus arrest, sinus block, or tachybrody. So these are the four components. And these are the primary, what you call pathology of the patient. They can present with junctional escape, lower atrial escape, or ventricular escape. Means ventricular, broad QRS, narrow QRS, or junction means it will be a narrow QRS escape is there. Escape means the rhythm, sinus is not giving, means there is no P wave, and you are getting a junctional beat, or you are getting a ventricular beat, or you are getting a P wave, which is not from the sinus. In place of a positive 2, 3 AVF, it will be negative in 2, 3 AVF. Means it is not coming from the sinus node, it is coming from the lower part of the right atrium, or it may be sometimes the left atrium also. So it means the SA node is not functioning properly and something is taking over. It may be atrium, it can be node, it can be ventricle. So sinus nodal disease can be diagnosed by seeing that there is no P waves, or the P waves is not of the sinus morphology. Okay, that's why when we are writing the rhythm analysis, the first word is normal sinus rhythm. Means the sinus is producing the beats, and after that, it is being conducted or not, on that we are going to decide. So sinus nodal recovery time, last time we have discussed. In this, what we are going to do, how much time we are going to pace, how much time and where we are going to pace. What is sinus nodal recovery time? Kotesh, it is for you. 3 to 5 seconds. Sinus nodal recovery time is the pause followed, means when we are pacing right atrium, please vibrator mode में डाल दीजिए. If we are pacing the right atrium for 15 to 30 seconds, after that, what is the time from the pacing to the next sinus beat it is taking is called the sinus nodal recovery time. Okay. So if we are paced for 30 seconds and then the interval after the first sinus beat is coming, that interval we have to measure it. And it should not cross any time more than 1225 when the pause is happening, or it should not cross any time if the baseline, what do you call, so this is called, we have paced here, okay, and this is sinus beat is coming here. So this time, whatever it is coming, it is 117. So it is 1325 is the time period. If it is crossing that one, it is called sinus nodal recovery time. That is one part. But at the same time, this sinus nodal recovery time has to be corrected. What is the baseline rate? Baseline rate it may be 1,000. And the sinus nodal recovery time means your base rate is after this one, whatever the rate is coming, that will be, I think it is here. So it is 1189. So after that, the second beat is there, no? That you have to minus it. So difference between the paced, paced followed by the baseline is called corrected sinus nodal recovery time. And that is fixed. 525 crossing anytime is taken as abnormal. So that is the indication of pacemaker. And this, I think last time we discussed baseline HV interval. So infrahasian, suprahasian, and intrahasian, 3 types of blocks are there. Means if AV nodal disease is there in and around, then we have to get the HV. So HV is prolonged. How much is the normal? 35 to 55. 55 above, prolonged. More than 100, indication of pacemaker. More than 75 with symptom, it is indication of pacemaker. Now, suprahasian, infrahasian, how you are going to differentiate? On EGM, how you are going to, it is a suprahasian versus infrahasian. Yes, what? What your? Huh? Huh? No, what was the finding on which you say that is infraindian versus supra? There is a P followed by, there is no QRS. You are getting a P wave. How you are going to say that it is supraisian versus infraisian? Forgot. Last time, times, 3 times I told. You have to see the his signals. If his is present, infra or supra? Infraisian. If his is not there, it is supraisian. Means his, before that only the things has been blocked. And intraisian is somewhat difficult to identify unless you are putting a quadripolar catheter or octapolar catheter and you are seeing the proximal and distal his, and it is separated by 30 milliseconds. Okay, so intrahasian more than 30-second difference between the H1 and H2, what we call a proximal and distal. If you are getting a his signal, it is a infrahasian. If it is a no his, it is a suprahasian. So getting a his signal followed by QRS is bad or good? If you are in a his signals, block is developing and his signal is present, is it a good sign or bad sign? Selin? So I'm saying this is bad or this is bad? This is one. This is supraisian, infraisian? Yes. And this? Identify na AHV, A no H. Okay. AHV, A no H means which is good? This is good or this is good? Or if I have to say which is bad? And block is never a good thing. So this block is bad or this block is bad? Why? दोनों में नहीं, इसमें भी तो QRS नहीं है. There is no QRS here. There is also 2:1 block is going on. That is also 2:1 block is there. Which one is infra and which is supra? See, this is bad. And the reason is the H is whenever you are getting H and followed by there is no QRS or you can say infrahasian block. Infrahasian means you have already damaged the his. There is the next escape is ventricle. So ventricular escape is not a reliable escape. The patient can escape. So this is a very what you call difficult. Difficult means the patient is having a bad AV conduction disorder, or if you are doing ablation, it has happened means patient has to go urgent pacemaker. While in this one, though it is also not a good thing if at all the patient is in, but it is a suprahesian. So here there is no H, so it may be due to the vagotonia, means patient is having high vagal tone, then also this type of things will come. So 2:1 AHV, AHV, and this is AHV. So this is the two types of second degree type 2 block. In the first, we are able to see there is no A, this is suprahesian, and this is infrahesian. So H will identify whether you are doing. What is this? AHV, AHV, AHV. What is this? Supra, infra. Itna क्यों time? Why the time is taking? Supra is and there is no H. Now according to the proper class for today. So infrasion, suprasion is clear. SNRT is clear. These are the two things for the Brady protocol. After that, before that, whatever you have to measure the basic interval, AH interval, HV interval, QTC, PR, all those things. So that is a baseline followed by Brady protocol. Now we are coming to the Tachy protocol, Tachy evaluation. So there are programmed PES. We use the word PES, programmed electrical stimulation. So it consists of 3 types of pacing: incremental, decremental, and extra. हम लोग इसको when we are in the cath lab, we will be saying burst करो, extra दो, burst करो, extra दो. These are the words you are using, na? But if you are going to read in the book, you will not get these words. So when we are saying burst means incremental pacing. Second is decremental pacing. The word we never use in the cath lab. Decremental conduction we say, but decremental pacing नहीं कहते हैं. And third is extra. So burst, ramp, extra, burst, ramp, extra. What is the difference that we'll discuss? PES, programmed electricity, is used to measure. Why we are using it? One is how good the myocardium is, the conduction property of the myocardium, refractory period means how much time it is taking for getting relaxed, means in that if you are going to stimulate, it will not. Second, the conduction property of the conduction system. So how is the SA, AV, all those things is conducting. Pattern of myocardial activation. So it is concentric, eccentric word you use, that is in and around the pattern of myocardial induction. And tachycardia characteristics. So when we are bringing the tachycardia, we are going to characterize how it is initiating, with jump, without jump, termination, how it is terminating. It is terminating with H, it is terminating with A, or it is terminating with V. And for the differentiation of atrial ventricular tachycardia, or what you call SVT, it is AVRT, NRT, or atrial tachycardia. So characterization of all those things are needed. So first is incremental. So how we are going to do is the performance of EPS study, the HRA and CS. These are the means when we have to pace it. One is the we can pace from the atrium, and second is we can pace from the ventricle. These are two places we are keeping. One is normally we put the what do you call ablation catheter in our lab. We put the ablation catheter in the ventricle, and one is in the CS. We never put HRA, means high right atrium uh, catheters, because we are keeping three. One is ventricle, one is his, and other is in CS. So three wire EP study we do. Sometimes we have to do wire EP study. Most of the time we don't do, because we have to again puncture and keep one more additional catheter. And after that, we are going to do right atrial straight pacing. What use straight pacing means we are just pacing it at a particular rate. That is called straight pacing. Means we can say that, okay, go for 400 cycles and 350, 300. So that is called straight pacing. Decremental atrial pacing. So here we are using the word incremental, means burst pacing, and this is called straight pacing also, but it is fixed rate. Decremental means every beat, 300, 200, like 330, 220, 300, 280, 270, 260, 250. Every next beat is reducing. That is called decremental. So ramp में कैसे होता है sir? So here the rate is increasing every other beat. That is called ramp. And extra stimulus, I will come. So programmed atrial stimulus, extra stimuli. We are giving a train of 8 cycles of normal, means 400 beats followed by one extra. Okay. So that is called extra. Means we are starting a heart rate of 400 cycle length, and we are saying, okay, put one extra. So that will be called S1, S2 protocol. Means we are giving one cycle length. And why we are giving one cycle length and then giving extra? We are giving 8 beats followed by one extra beat. Is it there or not? What we use extra. So why we want to give 8 or 7 or 6, whatever the initial beats, and how to identify how much we have to give it? These two questions. कौन है वहाँ पे, बोलो चुप रहेगा तो? You are in the class now. You are all the. Why don't you ask, sir, why you are giving 8 beats? Why not a 2 beat, 3 beats? So heart is having its own rhythm. It is running like if a young person is there, it is 70 beats. Or you can say 100 means 1000 beat cycle length is going on. Now you want to give one extra beat. So what we are going to do, you have to increase the heart rate to a particular rate, and then you should give it. Because first part we are seeing the pacing, what you call pacing threshold and sensing threshold. This is the basics first part of the EP study. After that, you start pacing it. So what we have done, we have seen the heart rate is around 1000 milliseconds. Now we want to start the pacing protocol by giving the extra. The time saying 1000, so you have to start 900, 800, 700, either any cycle length, which is less than, or with the heart rate should be more than the normal rate. If patient heart rate is 70, you want to pace at 80, then only you are going to give your own beats. Otherwise, it will compete. So 70 beat, you are not going to give it. So what you are doing, if the patient own heart rate is 70, you are going to pace with 80. So whatever the cycle length means, cycle length is 1000, you are going to give at 900, 800. So 800 beats you are going to give first to stabilize the rhythm. So minimum 6 to 8 beats you have to give. This is means two trains are running. Now you want to compete with this train. What you are going to do? You increase the rate. So this is the first protocol. The rate of this car is 70 and you have put it 100 this one. So you are already at. Now you want to give the next beat. Okay. So 700, whatever cycle length of this one, maybe 700, you are going to give the next bit less than that. Is it there or not? So what we are giving? 500, 350, 350. Like that we are saying a word. So 500 is the cycle length. First, 8 bit, 7 bit. Usually it is the protocol that 6 to 8 bit minimum. It takes time to enter into the system to stabilize the rhythm. First, you have stabilized the rhythm. Okay, you have given at a rate of 500 beats, 500 millisecond, and you have put a heart rate. So your heart rate is always 120 beats is going on. Now you want one extra beat. So it's stabilized. Now you are going to give next beat at 350. So 150 gap is there on which the heartbeat is next beat is coming. So this is called S1, S2 protocol. This is S, this is S2. Okay. So here we are using the word S1, S2. If you are doing from atrium, you will say A1, A2. If you are doing from ventricle, you will say V1, V2, V1, V2. Is it clear now? So we are going to give S1, S2 protocol, S1, S2, S3 protocol. When you are giving one train cycle of 500, then you should give 350, then you should give 350. So this is S1, S2, S3 protocol. Is it clear now? And what is how you are going to choose the first basic cycling? You have to see what is the own heart rate. And above that, you can just reduce 20% of the heart rate. If it is 800, 1000, means it is your choice. You can pay 800, 700, but no, normally we start from, we have to bring two cycle lengths to identify. One cycle length is maybe 500. Second cycle length, we are going to take 400. So two cycle length and one extra we have to do. 2 second extra we have to do, and both the cycle length has failed to induce the tachycardia. That is one thing. Then what you are going to do? We give isoprenoline. Okay, and again we have to repeat it. Is it clear? So this is the way EP study goes. Why we want to stop the medicine for 3 to 5 days or 3 to 5 half life of the drug, and then we have to start the protocol. In the protocol, what we are going to do? First is state pacing. How much is it? By state pacing, we are knowing if we are going to activate the atrium, how much the ventricle rate is coming, how much it is saying, and what is the behavior that we'll see later on. And same thing when we are coming to the right RV, when we are going to put this one again, same protocol. RV state pacing means what you call incremental pacing, decremental pacing, and programmed ventricular extras. S1, S2, S1, S2, S3, S1, S2, S3, S4, up to 4, up to 5P. Sometimes 5 also we give. But in our system, we are not having that much. We can go up to S3 only. So these are two things. Now, how to start it? In which patient you have to start atrium first? In which patient you are starting ventricle first? Any clue? So when you are going for narrow QRS tachycardia, okay? Narrow QRS means we are thinking about atrial tachycardia, you are thinking about PSVT, whatever you are, AVRT, AVNRT. Usually we start from the ventricle. Because, and the reason is, we want to rule out there is no ventricular tachycardia, first of all. And at the same time, we want to see the type of atrial activation during ventricle pacing. It is a what you call concentric versus eccentric. And third thing is, when we are starting from the ventricle, the tachycardia may not be induced. Okay. So we want to see the ventricle lower part, how like we are going to put a stent in the RCA. So, and we are fixed with that one. RCA, there is block. We want to rule out whether anything is there in the LCA or not. So we have done a check angio of left side and put the guiding catheter. Same thing here. If you are going for SVT, it means it is a convention. It is not a rule. It is a convention. Usually, we have to start from ventricle. And if you are thinking about ventricle, because you are knowing established already, the patient is having VT ECG. We want to rule out there any SVT is there or not. So like that. Or it may be SVT, which is behaving like VT. So both the things will be coming. So always make the opposite. If the ventricular tachycardia start from atrial protocol, if it is a ventricular atrial tachycardia, or SVT, start with the ventricle. So these two things we do. And when we are going to ventricle, as per the VT protocol is start from the ventricle. So there are two spaces, apex and RVOT. So you have to put the catheter first in the apex, start the protocol, burst pacing, decremental pacing, and finally extras. No tachycardia induced, go in the RVOT. Again, same thing. Incremental, decremental, extras, not tachycardia state, cycle and change. First time you have given at 600, now go to 400. Same extras on the apex. Then again to the apex. So 4 protocols you have to complete. Apex, RV. After that, you give isoprene. And then again repeat it. So that's why the protocols, we sometimes bypass it, but the protocol is you have to show from two spaces, 2 cycle lengths, with and without isoprene. Then it is going to be completed. You have given all these drugs and patient is not inducing any tachycardia. Means tachycardia means the EP study is negative for individual tachyarrhythmias from ventricle. Okay. When you are coming in the atrium, there is no change of means RVOT like that one. You have to just show with and without isoprene, incremental, decremental, and extras, and after that you have to pace it. So incremental pacing chamber is pacing chamber at a fixed rate, and the rate is increased. Pacing interval is decreased with each set of beats. And see how happens. This is, you can able to see. So this cycle length is different. You have given 10 beats, then you have changed again the cycle length. You are giving this. So there are 3 cycle, 1, 2, 3, 4. 4 cycle lengths are there, and you are pacing at a different. This is called the burst pacing also, and this is called the incremental pacing also. Okay. So you can think AHV. So S1, S2, 2, 3, what you call cycle length 380, then 360, then 340. And same time, what you are going to measure? AH1 interval, AH1. It was 45, 50, 55. What does it mean? See, here the things which I wanted to impress you. This is 45. This is 50, 55. What does it mean? Incremental or decremental? How you say incremental? 380 is big or 360 is big? 380, huh? 360, 340. Who is big? 340 is big. Big means the heart rate is higher. So this is called incremental pacing. Increase. 380 is lower heart rate. 360 is higher heart rate. This is again higher heart rate. Is it clear now? No issues? What is happening here? AH 45, 50, 55. What does it mean? Decrement. Very good. That thing you are not seeing it. That's why I wanted to point. When you are pacing from the atrium, the conduction through the AV node, whenever it will go, it will be decrement. The AH interval will be increasing 45, 50, 55. Okay. And at what type? 55 से सीधे 101 हो जाएगा. When there is a AH interval increases by 50 milliseconds by decrementing 10. मान लो this is 360. Okay. You have done to 340 and it was 50. It has gone to 100. Then it is called jump. Jump, what you are saying, na? Sir, jump आया. Book में it is not written. So that's why everybody start struggling when they come in the cath lab. Jump क्या बोल रहे हैं, block क्या बोल रहे हैं. So where to see, you should know. So what we are doing it, we are measuring the AH interval, and you will be seeing that he is measuring all the time AH interval. It is 45, 50. The time it is giving, increasing by 50 millisecond by decreasing the 10 millisecond of the pacing interval means jump. So this is a property of AV node when the dual pathways are there, means there are two pathways. Why we are saying jump? Whenever the dual pathway means AV node is having single pathway, what we are telling to all the patient ki AV node నుంచి పోతే పర్వాలేదు, ఒకటి ఎక్స్ట్రా వైర్ ఉన్నాయి దాంతో పొడితే ఇది షార్ట్ సర్క్యూట్ అవుతుంది. సో ద సేమ్ థింగ్ వెన్ ఇట్ ఈస్ గోయింగ్ ఫ్రమ్ ద AV node without any additional pathway, what is happening most of the time it is going here and the decrement will happen. But when it is switching from this to this, that is called jump. The conduction is not going to the fast pathway, it is going to the slow pathway. And this is defined by increase of AH interval by more than 50 milliseconds. So from here to here, it has taken more time, and that's why it is now going through the slow pathway. And the tachycardia has come. Is it clear now? Yes. So you see, the cycle lengths are increasing. Now coming to decrement pacing. So incremental pacing, AH interval will be decrementing, and the AV conduction is normally decrement. Okay? This property should be known. When you are pacing the ventricle also and atrium you are measuring, it is again decrement. If it is not decrementing from ventricle to atrium, what is the importance? Not reading, huh? Chalo, I will come on that point later on. So progressively, every beat means 300, 280, like that. When you are in decreasing the heart rate, we call as decremental pacing, ramp. Ramp, you have said there is no steps. It is all going up. So this pacing is normally, we don't use it. We usually use incremental pacing, 300, 10 beats, 280, 10 beats, like that we reduce it. So 300, then gap, 200. So this is going like a step, what you are saying. And this is a ramp, means all of a sudden it is increasing. So primarily it is used for induction and termination. Normally we don't use it. And the reason is atrial fibrillation, ventricular fibrillation can happen. That's why it is not a commonly used protocol. Okay. So you can see here, when we are starting, tachycardia has been sensed here. What is the heart rate? And it started every beat. See, this beat, this beat, this beat, this beat, this beat. All beats are different from the previous. And even in the pace ICD, you may be seeing that we are using this one. Okay. We will be using the word there, ramp pacing. Ramp pacing 80%. So what will happen? It will sense the heart rate here. Maybe it is a heart rate of 300. So 80% ka 300, how much it will be? So whatever cycle in, uski 80%, 20% reduction per, it will start pacing it. That is called this one. And every beat, next beat will again 20% of that. Again 20%, like that, it is called ramp pacing. Are you getting this point or not? It is not that difficult, but yes, if you are not attentive, you will miss it. So ramp is every beat is reducing from the previous beat. That is called, every beat is reducing from the previous beat. And incremental is every trail of the cycle is reducing from the previous cycle length. Both are different. One is beat to beat difference. That is called ramp, or that is called decremental. And when it is a train of cycles, means 8 or a burst pacing 8, then next burst pacing of 10 beats, it is reducing, then we are calling as incremental pacing. Okay. So it is sensed it and every beat. Next time again you have stopped it. Again it is sensing, okay, the heart rate is coming 280, it will start 280, 270, 260, 250, like that it will be going until it is terminating. Okay. Extras, you can see these are the stabilizing beats from S1 to S, whatever 8, 6, you will be seeing 6 beats followed by one extra. So S1, S2, S3, S4. So normally we will put a S1 and then S2, means one extra. One extra means S2, two extra means S3, three extra means S4. Okay. So extra S1 for EP study, knowing the refractory period. So different cycle. This is a one extra, double extra, and triple extra. So it is told that S4 means when S4 protocol you are using standard, any more than 3 would induce a non-clinical arrhythmia, and that is it would induce arrhythmia in a normal subject. So if you are going too aggressive, we use the word aggressively, we are inducing it. So if you are going to put 3 and going to 200 or 200, 180 millisecond cycle length, patient may develop VT or patient may develop atrial fibrillation. So we say that, okay, S1, S2 is okay, not inducing, given isoprene not induced, not inducible, or we are successfully ablated. But sometime we are, if you want to induce and we want that doubly sure that patient is not, and we can go for the S3 protocol also. Me putting. So programmed electrical stimulation, the stimulus or pacing artifact will be there. S1 is the first stimulus in the protocol that repeated at constant cycle length. Cycle length of the beat is called drive train. So it is usually 6 to 8 and used to establish the constant refractive period of cycle length. S2, S3, S4 protocol, depending on how many extras we are getting. And S3 above is always taken as a aggressive, this one. Gap phenomena we will be discussing later on. So for today, the first part we have completed, that is the what you call Tachy protocol. What we are doing, it is incremental, decremental extras. We start from the ventricle in PSVT and VT we start from the atrial pacing. And initiation, termination, and difference for the differentiation of the type of tachycardia and myocardial activation, how it is, whether it's eccentric or concentric, how the conduction system is behaving, that we have to see how the HV interval is behaving, and how is the refractory period of the AV nodal or the rest of the tissue we have to. And in atrium, we are going to go by from one location and start, either it may right atrial appendage or it may be from the CS, and we start pacing it. In RV, we are having two location. We have to show from two locations the number of S1, S2, S3 protocol or V1, V2, V3 protocol with and without the isoprene, and then we have to establish whether the patient is inducing tachycardia or not. And these are the ways. And what is jump? I have already, if you are reducing by 10 millisecond and AH interval is increasing by 50 millisecond, means the patient is having jump, or they're having two pathways in the AV node. One is called slow and fast. So the time the fast pathway is not conductive, which we call as a refractive period of fast pathway, it is going to the slow pathway, the tachycardia will come. So this we usually say. And decremental is a ramp, usually not utilized because atrial fibrillation, ventricular fibrillation can develop in this type of tachycardias. And these are the ways, means that we have to first sense the, so R wave has to be checked. If R wave is good, that R wave, we are going to start they use the word sync versus non-sync. So it is very important that pacing should be done in the sync, means you have to synchronize and then you should give it. Most of the time, our technician, they will be saying non-sync. That is not correct thing. So you have to sense the normal rhythm and then you have to give the extras. Otherwise, VTVF can happen. I mean, unnecessarily. We want to induce, but sometimes it unnecessarily non-clinical interval. Pacing drive train is whatever the cycle length of the patient, 20% you should reduce, put the thing and start pacing it. And you have to see how much the conduction is happening. So 1, 2, 3, S1, S3 means S4 up to that we will go. And sometimes S4 may induce a non-clinical arrhythmia also. Next class we'll be reading gap phenomena, that the VT protocols, establishing the refractory period, what is the refractory period of the different tissues. Sensing is performed and single atrial extra stimulus and single atrial extra, how we are going to identify. Okay. So these are the things will be coming in the next. Okay. Thank you. Light on chest.